Well, we'll go ahead and get started. So I want to be respectful of everyone's time. I'm Ashleigh Halderman, the current president of the Texas Association of Otolaryngologists. And welcome to our first lecture in this TKO High Yield Clinical Topics series. It's postnasal drainage, a comprehensive approach. And, when we were trying to think of content that we wanted to provide for our members, one of the ideas we had was to talk about those very common complaints that there's just not much research about, there's not much guidance about, and not much attention is paid to this on the national level at meetings and whatnot. But we see patients every single day that are complaining of this. So another name for this series might be the helpful but unsexy series. So postnasal drainage is our first go at this. Let's see. Oh, here we go. Sorry. I also wanted to remind everybody and invite everybody to our annual conference, which will be in Houston this year over November 1st and 2nd, and should be a great conference. We hope to see you all there. As I said, I'm Ashleigh Halderman, and I'm rhinology and skull base. And then my partner is Shumon Dhar, Dr. Shumon Dhar, who is one of our laryngologists here at UT Southwestern. And I thought it made a lot of sense to have somebody from the nose and somebody from the throat represented for this talk on postnasal drainage. So Dr. Dhar, thank you for joining us.
Happy to be here. Thanks.
So postnasal drip. Incidence, well, it's extremely common. And in fact, pretty much everyone on earth is going to experience it at some point in their life, be it from allergies or even just an upper respiratory illness. And the symptoms are variably described as a sensation of dripping or draining down the back of the throat, foreign body sensation, throat clearing, cough. People will complain of hawking or spitting up, pieces of mucus that can be discolored. And then I also included complaints of excessive mucus, because I think, unfortunately, when patients come to talk to us about postnasal drip, they may be talking about a kind of litany of things. And so we'll sort of delve into this a little bit through this talk. Surprisingly little is known about postnasal drainage, given that it is so common, but there are actually some potential explanations or theories. One is the kind of most obvious would be that there's overproduction of mucus. Other ones include altered viscosity of the nasal secretions, delayed mucociliary clearance, sensory dysfunction of the nasopharynx and pharynx. That's kind of a newer theory that's out there, one that I don't know a lot about. I think Dr. Dhar will be speaking a little bit about that and implications in the larynx, and also reduced clearing of normal mucus. So maybe patients that have dysphagia or just altered swallowing function. Drainage is thought to be caused in part by irritants or disease states causing inflammation. And it is actually just part of the normal aging process for a lot of these changes in mucus to happen. So a couple of common irritants that I wanted to bring up that are associated with postnasal drainage. Smoking is a big one. So anytime I have a patient come in and they're actively smoking, that's something that I'm going to immediately identify and sort of counsel on them on. And, the success of other treatment is kind of questionable when that's still in play. Surprisingly, CPAP, a lot of patients who use CPAP complain of symptoms of dryness, sneezing, runny nose, postnasal drainage, congestion, or epistaxis. And there's several physiologic things that happen to the nasal mucosa because of CPAP. So it actually reduces the cell permeability and mucus secretion rate, dries the airway surface liquid barrier, alters that mucus to water ratio, so it changes the viscosity of mucus. And this all leads to really thick, sticky, and globby mucus. The other thing the CPAP do is it actually induces inflammation. And over here, you can kind of see a couple of graphs from this paper that as the pressures went up, the inflammatory markers did too, and humidification didn't change that. So I have a couple of key questions that I highlight that I like to kind of ask myself when I'm evaluating a patient for a complaint of postnasal drainage. And I think one of the best things to ask yourself is it coming from the nose or the throat. Now, I think that we're all physicians. And so when we think postnasal drainage, we're thinking it's coming from the nose, it's draining down into the throat. But for patients, they may be talking about it's just always here, you know, and that's not necessarily postnasal drainage. A few sinonasal disorders that are associated with postnasal drainage or just drainage, as I call it when it's not from a nasal source: rhinitis, sinusitis, CSF leak, and again, aging process. And I kind of put into categories what I think these all cause. And so overproduction, you're going to see in these various disease states. Altered viscosity is going to be present in all of them. Delayed mucociliary clearance, I wouldn't expect for CSF leaks. And sensory dysfunction, I wasn't sure about. And I think that that's just something we're all learning more about. But I do think that that's something that is part of normal aging. Sinonasal tumors could be added to this list. They cause a post-obstructive sinusitis. Clumps of mucus can kind of gather. They can have their own kind of bloody drainage, but those are less common. And so some throat disease that are associated with drainage or postnasal drainage: GERD or LPR, xerostomia or thickened mucus, which can be either medication-induced, radiation-induced, or age-related; dysphagia, where a person's having ineffective clearing of the mucus and it leads to pooling, like you can see in this picture; sensory disorders, and things that Dr. Dhar will talk about. So this is kind of my second question that I like to ask myself, and I call this kind of my, like, if a tree falls in the wood, do you hear? If no one's around to hear it, can you hear it? So, you know, I like to kind of ponder if I think that a patient is actually producing excessive mucus and that's the cause of their symptoms, or is it that the mucus the patient is making is thicker, stickier, and therefore more noticeable and also harder to get rid of? And are they possibly less effective at clearing it? So when it comes to aging, there's a lot of changes that just naturally happen in the nose and the throat. Several things such as loss of the tip support, weakening of cartilage, drooping of facial tissue leads to nasal obstruction. We get atrophy of the mucosal epithelium, impaired mucociliary clearance, and there's actually changes in the nasal vasculature which make the nose less effective at moistening and warming inspired air. In general, dehydration is more common in the elderly population. And there's also really important changes to both swallowing and cough. So as far as swallowing goes, there's less clearance per swallow, secondary to a number of factors. This leads to increased pharyngeal residue and an increased rate of increased rate of clearing swallows required. And so essentially you have thicker, stickier, kind of globby mucus with the addition of less effective swallow and therefore less effective clearing mechanisms. And I think that these two things, particularly in the older population, lead to mucus collection or pooling and more symptomatic sort of mucus that's present. Xerostomia or salivary gland hypofunction, I think, plays a huge role in issues with drainage. You can see this in various disease states like Sjogren's. It can be radiation induced. It can also be medication induced. And, you know, I think that radiation patients or patients who'd had prior radiation are some of the patients that got me really thinking about this why the mucus is so bothersome in them. I think we've all had radiation patients that come in and are complaining of excessive mucus production. And we know that can't be true. The radiation has basically killed their salivary glands. It also alters the viscosity of the mucus. And so I know they're not making more mucus. But when I started to think about the fact that, okay, well, their swallowing is going to be compromised, that mucus is really tenacious, then I came to sort of understand that I think that there's so many factors going in to drainage patients are coming to talk to us about. And postnasal drainage that's actually coming from the nose is only a small part of that. So back to medication-induced xerostomia or salivary gland hypofunction. Kind of xerostomia and subjective salivary, those are kind of subjective symptoms. And objectively, you can have the salivary gland hypofunction, so less saliva is being produced. You can also have some objective sialorrhea, but those are the medications that can cause that. It's pretty uncommon. What's not uncommon is medications that cause salivary gland hypofunction. In fact, there were 56 medications identified in this systematic review that have a strong evidence of interference with salivary gland function. And I wanted to go over those because there are some very common medications. So antihypertensives, diuretics, beta blockers, calcium channel blockers, several medications for the nervous system. I would say that gabapentin is a big time offender in this category. Some other medications, so the SSRIs and some other antidepressants are, again, these are very, very common. And, cetirizine and levocetirizine, and I'm sort of highlighting this for something that I'm about to talk about. And now there's also a thing of drug-induced rhinitis. So what I guess I'm kind of trying to say is that when a patient comes in complaining of postnasal drainage, check their medications list because it could be a drug-induced. So my third sort of question that I like to pose when I'm thinking of a patient with this issue, and when I'm trying to think about what's going to be successful in alleviating their symptoms. And I think, in an aging patient or one with xerostomia or salivary gland hypofunction, is trying to dry up or reduce the mucus productive, or is it counterproductive? If it truly is an issue of excessive mucus, then something like an antihistamine is going to be helpful. But if that's not in fact the case, and it's more an issue of sort of the consistency, thickness of the mucus itself, then antihistamines are actually going to make the problem a little bit worse. And so in patients that you suspect that maybe that's not too much mucus, but rather it's tenacious, sticky, annoying mucus, then this concept of mucus management is, I think, very valuable to know. So you focus on hydrating the mucus instead of drying it up, thinning it out instead of, thickening it. So there's a lot of techniques that you can counsel patients on for mucus management. Hydration is probably one of the most common things that is underlying a person's sort of thick mucus issues. And, so I tell them how much they should be drinking per day. Throat lozenges, especially for people who are like, it's all down here. And I've had a lot of people get benefit from these throat lozenges. There's some throat sprays, steam inhalation, humidification, saline rinses for thick mucus. I prefer saline with xylitol in it because it is kind of a mucolytic. There's also clear. Nasal spray, alcohol, nasal wash is over the counter. It is natural and is also a mucolytic and can be very helpful. And then there's, of course, Mucinex, which you can start at 600 milligrams twice daily and then increase up to, I think, 1200 as needed. So this is kind of how I approach a patient with postnasal drainage. History is very important. You kind of get the basic information from them. Key factors are like, is it worse at any time of day? If it's in the morning, then I'm thinking maybe GERD or CPAP. Or if there's associated symptoms of sort of like heartburn, obviously GERD is something else I'm going to consider. From other history elements, medical history, I want to know if they have sleep apnea, are they on CPAP? And I don't know if Dr. Dhar is going to touch on this, but I think we're finding more and more that untreated sleep apnea can cause a lot of throat sort of irritation and sensitivity issues. Surgical history, with particular interest in if they've had prior sinus surgery or balloon dilation, because recirculation is something that can happen and it does cause really thick, drainage coming from the nose. Social, obviously, if they're smoking, and then a list of medications. So some history elements that may suggest it's not a nasal source. And I'm going to kind of focus on nasal things now and let Dr. Dhar talk more about the throat in a moment. In a person that has absolutely no other rhinologic symptoms, I'm always a little bit doubtful. Symptoms that are predominantly felt in the throat anybody who is sitting there just, throughout the whole appointment, to me, that's like, wow, this sounds like maybe an irritant, nerve irritation. The brain drainage is particularly bad in the morning. Again, I think that fits with a GERD or a CPAP picture. They have a history or they report heartburn. They're on a long list of medications, or they're in the geriatric population. So exam, I'm going to look at their oral cavity, and I do want to kind of see what their mucous membranes look like. Are they dry or are they normal looking? I want to see quality of secretions that are present. Do they have a lot of that kind of cottony, frothy mucus? Look in their posterior oropharynx to see if I can see any drainage. And then nasal endoscopy, it's easy when you see something like this, or you see definite evidence of CRS or ARS or a mass. There was one paper that said that 20% of patients with postnasal drainage will not have evidence of nasal secretions. I think that that's low. I think it's got to be so much higher, because I feel like it's unusual that a person comes in to see me for drainage and they have something on endoscopy. It's way more common that they have nothing. And then sometimes, depending on the situation, I may perform a flexible laryngoscopy to look at their larynx. And this is a photo. I always want to check for this possibility. So this is a patient who's had prior sinus surgery, and oops, sorry about that. And what we see here is some residual uncinate. What we see back here is a kind of posteriorly and inferiorly based maxillary os. And here is some thick mucus draining from the natural the os to the enterostomy. This is the surgical enterostomy. So this is recirculation. And I have a lot of patients who complain of postnasal drainage, and this is the culprit. So I want to go through some sort of pathways, treatment pathways, decision pathways. And I'm going to break it down as to, whether or not there are visible nasal secretions or not. And, when there are visible nasal secretions, then that's easy. Typically, I'm going to get a CT scan to evaluate them for sinusitis. And if they have sinusitis, I'm going to treat them for sinusitis. If they don't, then they're going to go into the rhinitis treatment pathway. Now, no visible nasal secretions on endoscopy is a little bit harder. If by chance they have evidence of sinusitis, like a polyp or edema, then, I think it's reasonable to still evaluate them for sinusitis and kind of go down that same pathway. But when they have when they have a completely normal nasal endoscopy, then I kind of break it down whether or not they have nasal symptoms. And so, the timing of the CT scan is really dependent on whatever the scenario, the specific scenario. And but I just wanted to kind of highlight the benefit of imaging in some of these cases. So here you have a nasal endoscopy, and I didn't get a great view on this of the middle meatus, but it was clear there were no mucus that you could see. So I'm not seeing any really thick, really nothing of note. It looks pretty normal to me back there. However, this is the CT scan from that patient. And so if I see a nasal endoscopy like this, but I have a CT scan like this, then I'm kind of a believer that their drainage issues are going to be from a rhinologic source. However, what happened to there? It's the same nasal endoscopy, right? But the scan is significantly different. Let's consider these two being the same patient. So I see nothing. I have no imaging, no evidence on imaging. I am very doubtful that this person's drainage is due to a sinonasal issue. It's definitely not sinusitis, but we'll kind of get into some more examples in a moment. Okay, so in a person with with nasal symptoms, then, playing the odds, rhinitis is incredibly common. I'm sorry, this is somebody with a normal nasal endoscopy who has nasal symptoms. Given how common rhinitis is and how kind of cheap, available, and sort of the risk profile of the medications, I think it's very reasonable to start with sort of empiric rhinitis treatment in these patients. I'll usually reassess them at 4 to 6 weeks. And if their symptoms are controlled, great, and continue treatment. Or you can consider offering them a posterior nasal neurectomy, neurolysis, whichever method you want to use. There have been some studies that suggested that this does provide some pretty good benefit to postnasal drainage complaints in patients with rhinitis. I would be very hesitant to offer this to a person who does not really have rhinitis symptoms or doesn't really respond to a nasal spray. I think maybe some other things need to be considered before you get to that step. So let's say that their symptoms aren't controlled. Since they have nasal symptoms, then I think going along the pathway of rhinitis treatment is still appropriate. So then I want to do a combination of intranasal steroid and antihistamine. And then if they're controlled, continue to treat posterior nasal neurectomy. But if they don't have any improvement, then that's when I definitely would say that you could get a CT scan. And if the symptoms aren't controlled after an initial trial, you could also consider that as well. Again, if they have sinusitis, you treat them for sinusitis. If they don't, then you need to consider some of the other alternatives, which I'll kind of go over in just a moment. So the flow chart for a normal nasal endoscopy without any nasal symptoms, I kept it kind of the same because, again, I think that rhinitis is so common and the treatments are so inexpensive and also pretty very low chance of side effects or risks that it's worth trying. But what I maybe wouldn't do is sort of advance to the dual therapy. You can also make an argument that if they don't have nasal symptoms and they don't have anything on nasal endoscopy, maybe we just go straight to either a CT scan or to considering some alternatives. So what are those alternatives to consider? Well, I put this into a couple categories of primary throat issue like GERD or LPR. And if that's the case, I will give them a trial of a PPI. And my preference is just 6 weeks of protonics. That might be, not the best thing to do anymore. I'm a rhinologist, so this is a little bit outside my wheelhouse, but I will try. And if a patient responds, then you've basically made the diagnosis. Now I'm not as comfortable sort of keeping them on a PPI and telling them it's okay. So I do kind of suggest that they engage their primary care doctor to talk about staying on it long term. But, response to this to me means we have a diagnosis. And then there's times that I'm going to refer people to laryngology because maybe nothing has worked. And a question that I'll kind of pose to Dr. Dhar as we're sort of switching over is like, which of these patients are appropriate to refer to laryngology? And then, the other alternative is that this could be a medication-induced salivary gland hypofunction, aging, or radiation induced. And in those situations, I'm going to review the medications, counsel the patient about the medications that they're on that could be contributing, and also sort of provide them with a handout of mucus management techniques. So, okay, I think we're going to switch. Well, and just one more thing. Overall, whenever I see a patient coming in for drainage, and most people are convinced it's coming from their nose. And I think that there's detective work that needs to be done to figure out what's really going on. So I tell them, we make an estimated quart of mucus per day in our nose and our throat. And the normal pathway for that to drain is down the back of our throat. And for some reason, this normal process is bothersome to you. This could be due to the fact that you're making increased amounts of mucus in the nose, or is something irritating your throat, which is making it more sensitive, or your mucus is thicker and stickier than it should be, or you're less effective at clearing it. Anyway, we're going to do a thorough evaluation and we will rule in or rule out a nasal source. So I think reassuring them that you're thinking of all possibilities and that you're going to go through an evaluative process, even if you don't end up helping them and you tell them it's their medications, I think that they'd really appreciate that effort and sort of being educated on something. And most of them are very accepting of the fact that they have to be on these medications. And so there's just not going to be able to change, but they're glad to know of things that can help. So, okay, Dr. Dhar, I'm going to stop sharing my screen.
All right. Well, thanks. So that looks like that's working. Um, well, that was really a fantastic lecture so far, Ashleigh. I really appreciate everything you've said and agree with a lot of everything. I think I'll probably try to like kind of touch on some things that you kind of alluded to, maybe in a little bit more detail, and things that you already nicely described, I'll kind of go over. But I liked your slide when, you were looking at the source of drainage versus the part of the anatomy that's feeling the drainage. And what they typically say is what patients say is what's feeling the drainage or what is reacting to so-called drainage is the throat. And so, or larynx, pharynx. And so you touched on these things. I'm going to kind of hone in on a few that you didn't kind of get too detailed on. Obviously, one of the more common things that we know about is extraesophageal reflux or laryngopharyngeal reflux. That idea has been kind of in the ether, I think, since the 90s. This idea of the mucus being thickened, and I'm not going to touch on medication. You already nailed it there. Radiation, age, dehydration. I think you nailed it. And then there's this idea of dysphagia, whereas if there's a buildup of mucus, typically the natural inclination for patients is to swallow it, to just basically get rid of the natural amount of liters of mucus that we're creating, and is the reason why this is building up just ineffective swallowing function. And this could be any type of swallowing dysfunction, from oral phase dysphagia, pharyngeal phase, pharyngoesophageal phase, or esophageal phase dysphagia. And then there's this kind of idea of just the innate hypersensitivity of the throat and what is causing the hypersensitivity, and this kind of artificial perception of drainage. And a lot of times you look and do a laryngoscopy and endoscopy on these patients, and there really is no drainage. And then you show them on the screen in real time as you're scoping them, and there is no drainage. And then it's like, well, we're actually dealing with a hypersensitivity. And I think I try to explain it as such, so as not to give the idea that it's not real, but just the idea that it's more of a neuropathy kind of issue. And we're going to get into that. So I think probably everybody has heard about extraesophageal reflux, reflux laryngitis, atypical GERD. It's pretty much described as the reflux of stomach contents, or even small intestinal contents back up into the throat, um, where they're not supposed to be. And why is that really an issue? Is because obviously the stomach is designed to withstand pH of 4 and below, whereas the lining of the esophagus and pharynx and vocal folds and larynx are certainly not. And this is just the issue there. So again, Dr. Kaufman first described this, I believe, in like the late 90s, this idea that laryngeal extraesophageal reflux can really be behind certain symptomatology. And it's pretty broad, though, from dysphonia, vocal fatigue, chronic throat clearing, excessive throat mucus, thickened mucus, chronic cough, dysphagia, globus or foreign body sensation in the throat, all these different things. And so it's I think that there's a movement now towards trying to get objective testing to confirm or deny the presence of laryngopharyngeal reflux, and not over attribute symptoms to LPR without some kind of objective evidence. So that being said, why does I kind of spoke on this already, but stomach contents composes of acid, as well as bile acids, and then of course enzymes like pepsin, which can cause damage of the mucosa. And a lot of times, though, that damage is not really seen as an actual lesion on the mucosal surface of the larynx or pharynx, but just an increased mucus production. So, which is kind of what we're here talking about. And so that's that. And so, how do we diagnose LPR? I think you've heard of the reflux symptom index, which has been around for quite a while. You probably use it in your clinics. Patient reported outcome measure, reflux finding score, which is looking at laryngoscopy and looking at these various findings. And these are things that we see in the clinic sometimes. Pseudo sulcus, which is really not a sulcus at all, but actually just inflammation of the infraglottis, obliteration of the ventricle, vocal fold edema, posterior commissure hypertrophy, all these things that are you all heard about and you all remark on, and I do as well, but they're not very specific. And so the question then is, are the RSI and RFS specific to LPR, or are they just general markers of inflammation? And I think that the general answer is probably yes. Some people at UCSF had done a study looking at people who are diagnosed with so-called LPR and who are unresponsive to anti-reflux therapy, and found that just with voice therapy, their RSI and VHI-10 scores, voice handicap index scores, improved. This is a really nice study actually done by a former fellow of ours when I was at Hopkins, Hannah Kavuchian, who's now in Kansas City. Did this study looking at patients who basically had all sorts of different pathologies, from LPR, paresis, paralysis of the vocal folds, polyps, cysts, nodules, papilloma, whatever. And as long as they were treated appropriately as to the underlying diagnosis, the reflux symptom index improved, and all that. And so that's, again, kind of one of these ideas that these tools that we have are not very sensitive at diagnosing LPR. And so then this idea is, of course, we need to visualize the larynx when you have patients who have these kind of throat symptoms like dysphonia and chronic throat clearing and globus and whatever it is, because a lot of the time we're going to find a alternative diagnosis that can explain their condition. And this study by Ryan Bransky at NYU kind of mentions that. And another study by Mark Fritz, who's now at the University of Kentucky, kind of also looked at the same thing and looked at basically all their patients that were referred to a tertiary care center with a diagnosis of LPR. And this chart kind of just shows you the variety of like alternative diagnoses that were found with during laryngeal stroboscopy. And so, our academy has put out some statement on LPR, and this was like almost 20 years ago. But they said that the incidence of heartburn in patients with LPR is less than 40%. And so they say that ambulatory 24-hour dual probe pH monitoring remains the gold standard for diagnosis. And then that patients with milder intermediate symptoms can be treated with diet and lifestyle changes, but that the majority of patients with LPR, however, require twice daily dosing with PPI no less than 6 months. And this is, again, a pretty common guideline that you probably all have seen. Clinicians do not prescribe anti-reflux medications for anybody without doing an endoscopy of the larynx. And then it's interesting to kind of look at, we have our perspective on things, but the GI folks have their own perspective. And this is from the AGA, the American Gastroenterology Association. And they basically say and think that people with extraesophageal reflux symptoms who have reflux and regurgitation, certainly fine to treat. For those that there is not a concomitant regurgitation or heartburn symptoms, not largely in support of treatment. I'm going to kind of go back here to our guidelines, and because we say that, we recommend ambulatory 24-hour pH impedance, and that's certainly, and there are actually objective ways to diagnose gastroesophageal reflux, or even silent gastroesophageal reflux. There's a thing called the Lyon classification, or the Lyon conference, that was basically came up with a set of guidelines that say this is what a positive pH study is, and it's where there's a over 6% acid exposure 5 centimeters above the lower esophageal sphincter. Now, there is not a similar type of classification system for diagnosing LPR. There almost probably every person who does 24-hour pH impedance testing, or even 48-hour wireless testing, they have their own ideas of what constitutes the diagnosis of LPR. For some people, it's like one incidence of reflux. For others, it's quite different. So there actually is no standard. There's standard equipment, and there's standard equipment to test for GERD, but there is not standard diagnostic guidelines to say one has LPR or not. It's not been decided on yet, which is suspicious, right? And so then if you have an LPR and you're maybe you have a patient with GERD symptoms and LPR, or you're convinced that endoscopically they are the classic LPR patient, the management is I think quite common. Obviously, lifestyle changes, weight loss is part of lifestyle. There have been some randomized studies that have looked at the Mediterranean diet in terms of its efficacy in helping patients with LPR, not just GERD, but LPR symptoms. And then there's acid suppression, which is PPIs or H2 receptor antagonists. And then there's barrier therapy. So barrier therapy can either be medical barrier therapy, which is basically with these alginates that have come on the market, Reflux Raft, Reflux Gourmet, Gaviscon Advance, that you can get, I think, online. These all have high concentrations of sodium alginate, which basically create a temporary barrier at the lower esophageal sphincter. And you can see that beaker in the lower hand corner of the screen is basically if you pretend the beaker is one's stomach without the fundus, and then the beaker is full of acid, the alginate basically gets activated and kind of forms a temporary cork, and then after a few hours dissipates. And I think it's certainly, and then these alginates have just general soothing effects on the mucosa when one swallows them as well. So it kind of has like a dual effect. And then, of course, there's surgical barrier treatment. Now, normally, the actual barrier between the stomach and the esophagus is the diaphragm, as well as the lower esophageal sphincter. In patients who have hiatal hernia or just a loose lower esophageal sphincter, this natural barrier is weakened, especially in patients with obesity. And barrier therapy includes various forms of fundoplication like Nissen, but then there are other looser wraps that can be done for patients that have underlying esophageal dysmotility. And then there's a new treatment called TIF, which is transoral incisionless fundoplication, which is basically a partial 270-degree wrap that's done endoscopically, but it's actually contraindicated for patients who have hiatal hernias, which are going to be most of your patients anyway. So the indications for TIF are quite narrow. And so it's interesting, but it might be overutilized in certain senses. And then kind of a new thing that's being looked at right now, it's not yet hit human phase yet, but someone has looked at using a medication that actually inhibits pepsin, and they found that an HIV protease inhibitor that you'll learned about in school actually has a inhibitory effect on pepsin, and this might be kind of a novel way of treating LPR symptoms or actually just extraesophageal reflux in general. Xerostomia, I'm not really going to get into as, possible because I think Dr. Halderman just really hit it out of the park in terms of what's there. The there's a great organization that I'll kind of plug. It's called the National Foundation of Swallowing Disorders, and this is like a patient advocacy group, and they have a website, NFOSD, and they basically have a really nice handout for xerostomia for our head and neck cancer survivors. And really, it's pretty, and I direct a lot of my patients there. But basically, it's either stimulation of glandular tissue if it's possible. In a lot of cases, maybe it won't be, and then saliva replacement. That's really the kind of the main things here. And you can look at this, but there are various methods for increasing salivary gland production, and then methods for replacing saliva. And Dr. Halderman talked a bit about this already, but take a look at that. That's a great resource for patients with swallowing disorders. And then, of course, I kind of think about hydration and then like the lifestyle modifications that we talk about. And I think that there's just the general, hydration, and frequent hydration. And it's all, it's so interesting when you ask your patients just like how much water you drink, or if you don't drink water, what else do you drink? And the answers you get, it's always interesting. Yeah, I think a lot of these issues can sometimes be managed with diet and expectation of that. And this is just kind of some general things that I recommend folks. And then dysphagia. Remember, I said earlier in the talk, make sure I'm not going over time here. Okay, I talked in the earlier about the absence of drainage of mucus is meaning you're not able to swallow. And so this, I always talk about dysphagia in these patients, and like, is there an undiagnosed dysphagia or something simultaneous going on? History and physical, you all know. Endoscopy, meaning taking a look in the larynx and taking a look in the esophagus, I think is pretty important because majority of time people are not very when people point to their throat as the cause of their dysphagia, 30% or more of the time, there's a lower etiology or two etiologies to the dysphagia. Very often you'll see, a patient pointing to their throat or saying they have globus sensation, and they actually have something esophageal going on, from EOE to reflux esophagitis and, erosions and all sorts of things. Anyway, dysphagia otherwise is worked up with after endoscopy and history and physical, instrumental evaluations like video fluoroscopic swallow study or MBS. FEAS is also something else one can do, flexible endoscopic evaluation of swallowing. I personally don't get a lot out of that actually, so I kind of prefer video fluoroscopic swallow study because it gives me an idea of what's going on during the pharyngeal phase of swallowing, which you can't really get during a FEAS. And then there are some really advanced diagnostics like pharyngeal and esophageal manometry. Esophageal manometry is much more worked out to determine and is the gold standard for diagnosing motility disorders of the esophagus like achalasia and ineffective esophageal motility, which is associated with reflux. And jackhammer esophagus to distal esophageal spasm, all sorts of things. And then endoflip is a new way of diagnosing motility disorders, which is looking at actually a balloon that's placed under anesthesia into the esophagus, and then the balloon is distended, and then the balloon basically calculates distensibility of the esophagus against balloon dilation. And that's looking at basically the distensibility index, and it's really measuring secondary peristalsis, not primary peristalsis, which can only be investigated when you're awake and actually actively swallowing. And then there's this other thing, which I think a lot of us see also, upper airway cough syndrome or neurogenic cough. And so this is where everything is really, or upper airway throat clearing syndrome. Maybe it doesn't generate the actual cough reflex, but it just generates the throat clearing, and then the throat clearing kind of turns into a cough. And I kind of consider neurogenic cough diagnosis of exclusion. That means we've diagnosed cough variant, we've excluded eosinophilic bronchitis, cough variant asthma, acid reflux, allergy, what is it called? Sinus related issues, whatever. Everything that we've already talked about has been kind of, looked at and either diagnostically evaluated, or what I do is I give them just a course of treatment and say, okay, we've treated you for these things and you're not improving. Let's move on. And there it is. And so these people will obviously say that they can feel the source of their cough in their throat. Sometimes most of the time it's midline. Sometimes they can point to it. Laryngoscopy is probably 99% normal, but I always do laryngoscopy just because there are some cases where you will see some lesions. And I think a lot of these lesions are going to be, in the absence of dysphonia or odynophagia or some other problem, they're going to be mainly reactive lesions to the chronic throat clearing of the mucus and whatnot. And sometimes you'll see hyperkeratosis or leukoplakia of the vocal folds, vocal fold edema. Sometimes you'll even see vocal process granulomas that can result. And it's not necessarily, that's the etiology of their cough. That's a byproduct of cough. And then I kind of like to I try to measure these patients over time. I look at the cough severity index that I believe came out of NYU or the Lancaster cough questionnaire, just to get a sense of where we are with these people. And then I think neurogenic cough is a multidisciplinary type of treatment, and I think the ENT has a small part to play, but a part nonetheless, to kind of put things together, I think, in these patients, because they see a lot of specialists, and I think it's kind of like our job to kind of gather the data and see what's going on. And I really don't mean neurogenic cough. I really mean neurogenic throat clearing. I think they're kind of on a spectrum. So we have a lot of our patients we send for cough suppression therapy and I tell them, just so they don't think that I'm telling them they're making it up. I say, regardless of the cause of the cough, whether it be GERD, whether it be allergy, whether it be whatever, cough is suppressible. For whatever reason, cough is suppressible. There's a really interesting group, I believe in Montana, led by Laurie Slovarp, who's looking at cough desensitization therapy, where progressively increased doses and concentrations of aerosolized capsaicin are given to the patient and during cough suppression therapy to basically desensitize them to to um, to stimuli. Because what happens is there are physiologic stimuli that we all experience. We all have reflux, by the way, but we all have physiologic reflux. And so, we all have these, our larynx is constantly being bombarded with things, temperature changes, pH changes, tactile irritants, whatever. And our chemoreceptors and tactile receptors and are being triggered, but we don't, it doesn't elicit a cough reflex, or doesn't elicit a throat clear, or doesn't elicit a globus sensation or a problem or a symptom. And so I think it's kind of a modification of the sensory aspect. And so we've all, kind of tried things like gabapentin and Lyrica, which is usually not covered, uh, and then tricyclic antidepressants like Elavil and Tramadol. And they all work to some degree, but sometimes not completely. And sometimes patients, after being slowly titrated up on these medications, kind of reach a plateau. When you use these medications, you have to start very low. Like if I'm using amitriptyline, I start with 10 milligrams for the first week, second week, 20 milligrams, third week, 30 milligrams a day, until they either reach a limit and their symptoms are controlled, or they start to experience side effects, which can be dramatic in some patients. Tramadol is actually a pretty good medication to help with this hypersensitivity issue, or visceral hypersensitivity. The issue with Tramadol is I have a hard time getting people off Tramadol. I feel like once they get on Tramadol, they're on Tramadol. And so I really try to limit the amount of tramadol I prescribe, just because it can become a bit of a nightmare. It's not particularly an addictive medication, even though it is opioid related. It's just not something I feel like I'm able to taper them off as easily as the others. And then, of course, there's these superior laryngeal nerve blocks, which Blake Simpson really did a wonderful job of kind of spreading the word on. But superior laryngeal nerve blocks have been around, for many, many years. And initially, they were being used for basically adjuncts to awake intubation. So if you were going to do awake fiber optic intubation, the anesthesiologist would sometimes do these nerve blocks in addition to topicalization and inhaled lidocaine nebulizers and stuff like that. And that was the original purpose of these nerve blocks. But then it was found to have some benefit in neurogenic patients. And I do these, and it's very easy to do these. Anybody can do them. Basically, you feel for the greater cornu of the hyoid bone right above the upper border of the thyroid cartilage. You feel for that bone, that greater cornu, and then you just go 1 centimeter inferior, 1 centimeter medial, and that's kind of that area at the thyrohyoid membrane where the internal branch of the superior laryngeal nerve is entering the larynx. And you basically kind of bounce your needle off the membrane and then just slowly inject. But you have to pull back first to make sure you're not in a vessel, of course, and also to make sure you're not in the airway. I think the first couple of these, it's hard because it's pretty easy to pierce through the membrane and end up in the airway. And the patient says, "Oh, I'm kind of feeling a dripping in my throat." And it's because they are. Usually they have a globus sensation after the injection, but they really shouldn't feel dripping. That's probably because you entered the airway. And so the first few of these, it's nice to actually do with a scope in their nose. And so you can actually look at the larynx and make sure you haven't inadvertently entered the pharynx basically with your needle. And then it's just a slow injection. I use 0.5% bupivacaine, 1 cc of that mixed with 1 cc of Kenalog 40. And that's pretty much what Blake Simpson has kind of published on, as well as Vininder Dillon at Hopkins has written a lot about it also recently. Anyway, and then the future is this new medication that's currently undergoing, I believe, phase 2 or 3 trials. I don't think it's FDA approved by any means. It's this thing called gefapixant, which is a P2X3 receptor antagonist, and it's primarily being looked at as a medication that's going to help with neurogenic cough, and these kind of things. So that's kind of currently in the pipeline. It's not FDA approved, I think the last time I checked, which was today, I think. But that's kind of where we are right now. So that's
Yeah.
kind of
Oh,
what I have
sorry.
to say about this. Yeah.
Okay, thank you so much. I just wanted to open up an opportunity to anybody who has questions for either of us.
Ashleigh, this is Dr. Lee.
Well,
I'm a old retired ENT who has pretty severe vasomotor
oh,
dysfunction, vasomotor rhinitis.
mhm.
Any suggestions on how to treat that? Because
Have you
it's
tried
very annoying.
oh yeah. Have you tried ipratropium bromide, 0.06%?
No, I have not tried that.
Ooh, I think that's going to be life-changing for you.
Ah, okay, that's
Y-
good.
Yes. I like to do the 0.06%. There's a 0.02, 0.03, but I think 0.06 is sort of consistently effective. Um, and a lot of times I will tell patients, if eating is a trigger, do it like 20 minutes before mealtime. And if it's just sort of happening spontaneously, I still think meal times are a good time to do it because you do it 3 times a day, and that's about how often you want to use that. So,
Right, right.
mhm,
Yeah.
yeah.
My trigger is can be meals,
Hmm.
especially if I eat a big meal.
Hmm.
And the other trigger can be temperature change.
Yep. Yeah.
And I do the best to treat it, but it is
Yeah.
very annoying. But I
It's
appreciate
very
that.
aggravating, major quality of life impact. So,
Yeah, yeah.
my email is ashleigh.halderman at
Mhm.
utsouthwestern.edu.
Okay.
I'm sorry I didn't include it, but feel free to contact me. Okay.
Thank
I'd love to
you.
know
I
how you
thank you. I
do.
appreciate it. Yeah, I
Okay.
appreciate it.
Yeah.
And I really enjoyed your this webinar. It's quite nice.
Great. Excellent.
Okay.
I just wanted to plug one thing real quick before
Yeah.
I forget. Where I'm part of the ABA, which is this ENT organization that we're putting on a webinar for patients with vocal cord paralysis and for providers too. So if you have any patients who have vocal cord paralysis, by the way, and have lots of questions, this is a free webinar for them. So this is just some information that they can kind of look at. And I've been handing it out to my patients so they can kind of do this. And it's free for them. The registration code is right there, ABA webinar 24, and they can just join for free. And if you guys want, can join for free also. And all that. So anyway, I'm going to just stop.
I have a question. Hello, am I audible?
Yes, we can hear you.
Yeah, I am Dr. Kamal Goyal. I am Senior ENT Consultant in Manipal Hospital, New Delhi, India. My question is that how many of your patients actually go for surgical barrier with complaints of LPR? How many they opt for surgical solution for LPR? Because it
So
is very difficult to convince patient to go for a surgical solution for a complaint like cough or like LPR.
yeah, I would say for me, I would say extremely rare, and I would not really encourage that, honestly. I think that I would encourage it if they have LPR with concomitant regurgitation and heartburn. I think if they don't have regurgitation and heartburn, in association with LPR symptoms, I would not be overly into it. And the reason is because a lot of the time, some of the foregut surgeons are a little bit hesitant to operate on chronic coughers, or because they feel like they may even have issues with just hold the actual wrap holding because of the chronic coughing. And so there has been published data that said that and I think Sadloff's group has published it, and other groups have published, improved extraesophageal symptoms with these surgeries. But it's pretty. I don't. I try not to bring it up, honestly. I try to kind of like manage expectations, and also say that there's a complicated version of this, which is dysphagia, esophagitis, Barrett's esophagus, and stuff like that. And then there's uncomplicated, where symptoms are globus and mucus and things like that. And I think we need to keep things in perspective and not over medicalize and over treat people with medications and surgeries and try to kind of empower them more. And it's funny because you look on some of these like patient education or Facebook groups and stuff, and you like see patients talking to each other. And a lot of them are more into dietary modifications and lifestyle changes than I think we give them credit for. I think we don't give them credit and say like all these patients are going to do is like want a medication and want surgery. But I think, you know, if we give them the choice or at least couch their symptoms as uncomplicated or complicated, and I kind of just really reserve surgery for complicated patients, you know, people who have those things that I just mentioned. I think I go in that route. I try not to convince people to go overboard.
Thank you.
Any additional questions?
Hello, Brian Humphreys. I'm not
Hi,
on
Dr.
video.
Humphreys.
Can you hear me? So I was honestly expecting more to be said about the sphenopalatine nerve blocks and ablations. So, you know, we have radio frequency techniques, we have freeze techniques, and I have a relatively short fuse to get to that. People, and a wonderful success rate. So, you know, Martin Satardi at UTMB, actually UT Houston, did a study saying that it's at least 80% effective. Of course, the company tells us it's closer to 100. I never believe numbers like that. So I just wanted, you know, your comment on these phenolpalatine nerve ablation techniques.
Yeah, thank you for sharing that. You know, it's definitely, I've become more and more of a believer. I think a lot of the initial studies were looking at rhinorrhea specifically. So, you know, I do think it's something that you can absolutely offer these patients that has great outcomes. At the end, I wanted to make sure I kind of talked about some of these things that are maybe not well recognized that and I'd say probably the number of patients who have these complaints that are going to benefit from a posterior nasal neurectomy. At least the patients that I see with complaints of drainage, I really feel like most of them fall into this category of it's not rhinologic. It is sometimes, absolutely. But, you know, I think that the concept of the thick mucus and sort of these changes that happen has to me really opened up some doors and allowed me to help a lot of people that I don't think I would have been able to help otherwise.
Very good. I want to compliment both of you for your excellent presentation.
I guess my question to you, Brian, is are you doing these on patients with anterior kind of drainage or posterior drainage?
All posterior.
Mostly posterior?
Yeah, largely posterior. Yes, sir.
Interesting.
Do you trial any nasal sprays or do you trial anything
Yes.
or like kind of
I
what's your
always
selection
trial.
and process?
Correct. I always trial a month of sprays. Actually, I combine the ipratropium bromide spray with the fluticasone or steroid spray. And I find that reimbursement is actually tied to that hoop. They want you to jump through that hoop, particularly the steroid, before they actually approve it. But I think the ipratropium truly probably keeps about at least a half of the people out of candidacy because they come back and say, "Oh, yeah, that spray was better. I'm better." But if they still have a failure, then I have a low threshold to move ahead, and I experience a success rate similar to the 80% improvement that Dr. Satardi reports.
That's great.
Thank you. Okay, well, I think with that, we will conclude. Thank you all so much for joining us. Again, this is something that we hope to kind of continue to build on, to continue to select topics that are just things we see all the time, but there's not much discussion around them. We want to try to be really meaningful in sort of the educational things that we present to our members. We really appreciate your time tonight. I would love to hear from you feedback about, what you liked, what you didn't like, topics you would like to hear discussion on. Just let us know, okay? All right. Good night, everybody.